we're now going to begin our conference this morning. And our first speaker is from Sydney Local Health District, and her name is Chelsea Larkman. Chelsea is a senior speech pathologist at Concord Rehabilitation Hospital, and she works in the acute stroke ward. So anybody who's been at Concord will have met Chelsea, but she's here today to help us to understand a little bit more communication difficulties that people face post-stroke. Welcome.
Thanks, Michelle. Good morning, everybody. It's lovely to be here. This is my first Creating Connections conference, so it's nice to be here with you all. So, there we go. Yes, so I'm going to talk to you this morning about some of the changes to communication that we might see after stroke. So if I do my job well this morning, by the time we finish, you'll have a better idea of what communication is, what the different components of communication are, and also some of the acquired communication disorders that can result from a stroke, the role that speech pathology can play after stroke, and some strategies that can help with these communication changes. So, communication is essentially an umbrella term for a whole range of components. I'm so sorry, the slides have multiple components that load. So we have speech, language, voice, fluency, and cognitive communication. The terms speech and language often get used interchangeably, but speech pathologists very much tease these two things apart. So essentially, different parts of the brain are responsible for different aspects of communication. Typically, the left hemisphere of the brain is responsible for language, whereas the right hemisphere has more role to play often in, cognition and how that might impact on communication. And then within the left hemisphere, we have the motor cortex, which has a role to play in planning and programming for speech. Okay. So when we think about speech, so speech is essentially how clear speech sounds, how well the sounds are articulated, and how easy they are to understand. And within speech, after stroke, we get two different motor speech disorders. So one is called apraxia of speech, and the other is called dysarthria. So we'll start by talking about apraxia of speech. So apraxia of speech is essentially a difficulty with planning the movements for speech. So the muscles themselves might be intact, but the part of the brain that's responsible for providing the pattern or the plan of how to move the muscles to produce the sound is affected. And so what we get are distortions to the sounds, both consonants and vowels. We get an overall slow rate of speech, and also this tendency to equalise stress. So when we talk, we have a natural intonation pattern, that rhythm and flow across our speech. And so we might put more emphasis or stress on different parts of the word. With apraxia of speech, what sometimes happens is that the syllables in the word get equalised. So in a longer word like banana or caterpillar, they might start to sound the same. So rather than banana, it might be banana, caterpillar, and so it all sounds a bit the same. Apraxia of speech might also be called dyspraxia, just FYI. And in terms of neuroanatomy with stroke, apraxia of speech can often occur with aphasia. And that's because of where the motor cortex is in the brain. It's right next door to the language centres. So they can occur in isolation, but they can also occur together depending on the nature and the extent of the stroke. Okay, so if we go back to our motor speech disorders and we move on to our second motor speech disorder, we have dysarthria. And essentially, dysarthria is a fancy way of saying slurred speech. So the difference between apraxia of speech and dysarthria is not only due to what part of the brain is affected, but with dysarthria, the muscles themselves are affected. So instead of the motor plan and the pattern being impaired, it's really the nerve supply to the muscles themselves. And so the muscles might be weaker, they might have increased tone, they might be incoordinated. And as a result of that, the strength, the speed, the range of the movement of those muscles for speech can be affected. We talk about dysarthria being a group of motor speech disorders, and we get different types depending on what parts of the brain have been affected. So someone who has had a stroke in the cerebellum versus in the left hemisphere, the right hemisphere, their dysarthria can present differently and can sound different. Okay, so that's the speech side of things, apraxia and dysarthria. Moving on now to language and language changes after stroke. This is what we call aphasia. You might have also heard it called dysphagia, and they're essentially the same thing. It really harks back to more of a medical model that differentiates based on the Latin of aphasia, meaning no language, versus dysphagia, impaired language. As a profession, we're trying to encourage just using the one term to avoid confusion, because there's another term called dysphagia that refers to swallowing, and these often get mixed up. So aphasia is a language impairment. And what that means is that a person might have trouble understanding what they hear and processing that language. They might have trouble speaking and saying what they want to say, getting the words out, organising their sentences. They might have trouble reading and understanding what they read. Writing, either with pen and paper, texting, typing, gesturing, and also using numbers. And every person's aphasia might present differently. So some people with aphasia might have difficulty with just one or two of these things. Other people might have trouble with all of them. It just depends, again, on the nature of the stroke. And it's important to know that aphasia is a language difficulty. It doesn't influence intelligence. So a person with aphasia knows what they want to say, but they just can't say it. It hasn't affected their intelligence. There may be co-occurring cognitive changes because of the stroke, but the aphasia itself doesn't change intelligence. And aphasia is really, really common. So we estimate about 1/3 of stroke survivors will experience aphasia. So what does aphasia look and sound like? Some of the common features are that they have word-finding difficulties. This is the hallmark feature of aphasia. And many, many people that I've worked with who have aphasia say this sentence: I know what I want to say, I just can't say it. It's that having it just on the tip of your tongue, but you can't get the word out. And because of those word-finding difficulties, they might also make some errors in the words that they do produce. So the words might sound close to the one they're trying to say, or it might be closely related. So instead of chair, they say table. So in the ballpark, but not quite right. We also sometimes see made-up words. So it's not a recognisable word, it's a completely made up word as they're trying to express themselves. And when someone with aphasia is having trouble getting the word out, they'll sometimes talk around the word and describe it. So if I was trying to think of the word for phone, I might say, oh, you call people on it, it rings, you can text. And so you know what I'm talking about, but I just haven't quite got the word. And we also see errors in grammar in terms of sentence construction and sentence organisation. And then depending on the type of aphasia, it might be more non-fluent and so really effortful and halting and trouble getting more than a word or two out at a time. Or, on the other hand, it might be fluent and sound like normal speech, but the words themselves aren't really very specific, or they don't make sense, or it's not quite put together in the right way. So this is a busy slide, but it's just to illustrate that, as I said with dysarthria, we've got all different types of dysarthria. We also have different types of aphasia, and it just depends on the presentation. So depending on where in the brain the stroke has occurred and what language functions have been impacted will give us a different presentation. And so speech pathologists will categorise someone's aphasia based first on fluency. So is it really hard to get more than a couple of words out, or can they put more words together? And then we step down to look at the person's ability to comprehend and understand language. And then we break it down further based on whether or not they can repeat. Really, this is only of interest to speech pathologists or other health professionals, because at the end of the day, we treat the person in front of us and we treat the difficulties that they're having. It really just gives us a common terminology to use. So if I got a referral for a patient that said they have a Broca's aphasia or a Wernicke's aphasia, I can already picture in my mind the sorts of difficulties that they're going to be having and what they're going to be like in a session with me. Okay, moving on to fluency as a component of communication. This is also sometimes called stuttering. We're probably all familiar with typically developmental stuttering that starts in childhood, but sometimes after a stroke, we can get a presentation of neurogenic stuttering. So this might be that a person has never stuttered in their life, and then after their stroke, they're having difficulty with their fluency and their stuttering. And what that might sound like is that essentially the rhythm and timing of speech is what we talk about with stuttering. And so they might repeat sounds, syllables, words. They might prolong sounds or get stuck on sounds. And this is just a little example of, repetitions versus prolongations. And essentially we treat it in the same way that we treat typical developmental stuttering. We use the same approaches to treat neurogenic stuttering. I'd have to say, I don't know statistics off the top of my head, but it's not that common. In the last 18 years, I've probably only had 4 or 5 patients with neurogenic stuttering post-stroke, but it does happen. Okay, voice and voice changes after stroke. The technical term for voice changes is dysphonia. And voice is often thought about as due to straining the voice or the way that you're using your voice. So you might, teachers notoriously have trouble with their voice from overuse. But in stroke, what we tend to see is related to the muscles in our larynx and how they're affected after the stroke. So in the same way that a stroke might impact on, movement of the arm or the leg on one side of the body, it can also affect movement in the larynx. And so one side of the larynx and our vocal folds may not be moving as well. And to get a nice, clear, smooth voice, we need our vocal folds to come together to give us a nice, smooth, vibrating surface to produce voice. And when that doesn't happen, we might have no voice whatsoever. Sometimes a person might have a stroke and they can't achieve any voice, depending on how much that movement is affected and is limited. or it might sound really rough, breathy, weak, or strained. Sometimes this might spontaneously resolve on its own as some of that movement comes back in that side of the throat. Other times we might have to try a bit of therapy, or sometimes, depending on the recovery, the ENT doctors, the ear, nose, throat doctors, might also get involved. What have I touched? Nope, nothing, good. And help with a bit of augmentation and try and help move that cord across perhaps. Okay, our last element of communication, so we've talked about speech, language, fluency and voice, is cognitive communication. And we most commonly see this in a right hemisphere stroke. And this is to do with this interplay between cognition and communication. And it will often be more subtle. It's not as obvious as someone really struggling to find their words, like in aphasia, or their speech being really slurred, like in dysarthria. And so it often goes undetected. They estimate that the incidence of right hemisphere cognitive communication disorder is somewhere between even 50 to 80% for people who've had a right hemisphere stroke. But it might be mild, it might be very subtle. The sorts of things that we see are things like difficulty with humour, sarcasm, metaphors. So language that doesn't really, you have to read between the lines and infer what someone means. Difficulty with really complex sentences. And in terms of reading and writing, we can see neglect. So I'm not sure how much you know about neglect in terms of neglecting maybe one side of the body, one side of the room. That can also be present in reading and writing. So the person might, as they're reading down the page, miss the left side of the page or the left side of words. And so it's also about learning to scan across the page and across the words. In terms of discourse or conversation, sometimes people can be tangential and they can tend to go off topic. You start talking about one thing and then before you know it, you're off on another topic. And it can be hard to stay on topic. People might talk too much or too little. So in any conversation, normally it's a bit of a back and forth, a shared conversation, we each take turns. If someone's having trouble with their cognition and communication after stroke, this can be hard to do. So you may not be able to get a word in edgeways, or you might have to do a lot of prompting to try and get them to engage in the conversation. The next one down, prosody, is about how we convey emotion in our speech. And so, you can pick up from someone's tone of voice how they're feeling. After a stroke, this might be hard to do. Or it might also be hard to express emotion through your own tone of voice. And so someone might sound really flat or monotone. And then we can have some issues with pragmatics, and these are things like eye contact. So again, in Western culture anyway, we tend to, in a conversation, make eye contact with the person that we're talking to make them realise that we're engaged and we're interested. That can sometimes be affected with a right hemisphere stroke. And then, to make things a bit trickier, insight and awareness of these changes can also be affected. So the person with the stroke may not realise that these things are happening. But if we think about all of those things, humour, sarcasm, conversation, eye contact, interaction, we can appreciate that that is going to have an impact on a number of things. Perhaps someone's ability to return to work, and also their relationships. You think about what makes you want to engage in a conversation with somebody, and if they either don't seem interested, they're not looking at you, or they talk too much, they talk all the time, that can make the other person think, oh, well, I don't. So we really need to be more aware and diagnosing and picking up on these changes to support people so that we don't have negative impacts on someone's relationships and ability to return to work. Okay, So what's the role of the speech pathologist in all this then? First and foremost, we want to be assessing and identifying people who have communication changes after a stroke. We want to diagnose it, we want to know how severe it is, what it presents like, and then we want to educate the stroke survivor and their family members about that diagnosis, about how that might impact them and what we can do to help. And we might give some strategies to the stroke survivor themselves, to their communication partners, to the other health professionals that are working with them. And obviously, we'll do some therapy. So I thought in terms of therapy, we might have a look at what the Stroke Foundation guidelines say that speech pathologists can and should be doing. So first and foremost, our stroke guidelines tell us that all stroke survivors should have, they should be screened for communication changes. And that if we identify that they're having difficulties, then they should have more comprehensive assessment by a specialist clinician, so by a speech pathologist. So that's the assessment side of things. And specifically in relation to aphasia, our guidelines say that assessment and treatment should be offered as early as tolerated. This is going to vary from patient to patient, depending on what else is happening initially after the stroke, how unwell they might be. But our guidelines do say that if someone can tolerate it and they're up for it, we should be getting in there and doing therapy as early as possible. Our guidelines also say that for people with aphasia, we should be giving therapy so that we can improve function. And then in terms of, the timing of that therapy, the recommendations are that in the first 4 weeks, we should really be trying to get in there and start therapy early, really capitalising on that neuroplasticity after stroke in the early stages. But having said that, we've also got some guidelines about then how much therapy at different times. So in the acute phase, so we're talking, the first 6 weeks after stroke, the guidelines suggest 2 to 3 sessions a week, 30 to 45 minutes. Trying to do more than that isn't necessarily going to get you more gains. So in terms of getting bang for your buck, 2 to 3 sessions, a decent length, 30 to 45 minutes is what we should be aiming for. But then on the chronic phase in aphasia, that's where we have stronger evidence for intensive therapy. So if someone is more than 6 months after their stroke, then that's where we want to be doing more intensive therapy. So, several days a week for several hours for multiple weeks. And also, in addition to the speech pathologist doing therapy with the stroke survivors, we also want to be training their communication partners on how best to communicate with them. So, that brings us for our last 5 minutes to strategies to support communication. And strategies need to target both people, the stroke survivor and their communication partner, because we don't just communicate with ourselves, we communicate with other people. In terms of strategies to support communication in aphasia, there is a program out of the Aphasia Institute in Canada called the Supported Conversation for Adults with Aphasia. And they focus on 3 key things. Help the stroke survivor to get the message in so they can understand it, help them get their message out, and then verify the message to make sure that we're all on the same page. So some things that can help a person with aphasia get the message in and understand it is using shorter, simpler sentences, using gesture perhaps to support our meaning. Write down maybe some key words or the topics so that the person with aphasia is not having to rely on auditory input alone. They might also see some key words to help them follow what's happening. Sometimes pictures can help just to support the idea, minimising other distractions. And then reading those other cues in communication. We don't just communicate with words, we communicate with our body, with our facial expression, with our gestures. And then to help the person with aphasia get their message out, sometimes we might need to ask yes or no questions, depending on how difficult it is for the person to express themselves. We really should just ask one question at a time. Maybe we ask questions that are more fixed and closed. So rather than saying, what would you like to drink? We say, do you want tea or do you want coffee? So that they've got something to choose from. Encouraging the person to try and communicate in any other way if they can. So if they can point, maybe they can write down some keywords. And give more time. People with aphasia need more time to get their message out. Okay. And then we want to make sure that we've understood each other, so we might also repeat back the person's message and recap to make sure that we're all on the same page. And then the person with aphasia themselves, in order to get more support, there are these things called little aphasia cards. So the idea is that they might carry it in their wallet, in their pocket, so when they're in a new environment with someone they don't know, they might show them this card to say, I have aphasia, and some strategies. So please give me more time, and you can have some specific strategies on the other side. And then some strategies that can help on the speech side of things and help a person be more clear when they're speaking is if you get stuck on the word and it's not coming out clearly, stop, take a breath, try again, slow down, and try and focus on each sound. Make sure you're facing the person you're talking to. You might want to try saying it in a shorter sentence or rephrasing it. And if you're really struggling and the person's not understanding you, maybe bring it back to just a couple of key words so that the other person knows what the topic is and they can maybe clue in a bit more. And perhaps we might want to use some other strategies, so writing, pointing, to help get the verbal message across. And things that friends and family can do to help someone who might have dysarthria or apraxia of speech. Similar to aphasia, be patient, give more time. It can be really, really frustrating to have trouble getting your message out. Minimise background noise to give you both a better chance to hear what's happening. Encourage those other methods of communication if it's appropriate, and ask questions to make sure you've understood. Okay. All right. I'm just conscious of time, so I won't go into the next slide because it's a bit busy, but there are also strategies that can support cognition and communication. Thank you.